So today we will be talking about Cushing's syndrome. So what is Cushing syndrome first of all? So Cushing syndrome is just you can say in simple words hypercortisolism. So there is increased level of cortisol in the body, and so that's basically Cushing's syndrome. And so let's talk about a little about the physiology here, just to know where the cortisol kind of comes from. So above we have the hypothalamus. So let's suppose this is the hypothalamus, and in the hypothalamus we have a nucleus, and that nucleus is called the paraventricular nucleus. So this is the paraventricular nucleus, and from there we have another gland. It is called the pituitary gland, and this is the interior. Let's say this is the anterior pituitary. So this actually from the paraventricular CRH is released, corticotrophin releasing hormone, and then acts on the anterior pituitary, and then the anterior pituitary produces a CDH. So this ACDH will then come here and act on the adrenals. So these are adrenals. These are on top of each kidney. So if this is the kidney, let's say this is the kidney, and on top of it is the is adrenal gland. So now the CDH will then act on the adrenal gland, and the adrenal gland will then, in response to the CDH, produce cortisol. So now anything that would cause increased cortisol, very increased cortisol, would cause Cushing's syndrome. So the general features. So general features of the Cushing syndrome. Let's talk about them. Let's go from the top down. So let's first start from the face. So what will you see on the face? On the face, you will see a moon face. It will be a rounded face. The face can be plethoric. There can be acne. You should look for hirsutism in the face, and then oral ulcer may also be there, so just look for those. And then coming down here, we will have the buffalo hump. You can see the buffalo hump here. And then when you come down, look for in the shoulder, look for proximal myopathy. And then under the armpit here, look for any acanthosis nigricans. And then on the arms, you can look for bruises, but bruises in general you should look for anywhere on the body. So bruises can also be there because cortisol, remember, causes atrophy of the connective tissue, right, of the collagen. So and also the skin. So the skin is really paper-like. So it will be paper-like, and it's really easy to break down the skin in Cushing syndrome patients. So especially the bruising would be in areas of trauma. For example, if there is a cannulation, if there is an injection given in a particular part of the arm or body, so that skin area would be bruised. So it is called easy bruising. So then on the chest, let's go to the chest. And in the chest, you will see gynecomastia. So gynecomastia can be there on the chest. And then obviously in the arms, you should look for blood pressure here because the blood pressure is elevated here because cortisol causes hypertension. So then coming down to the abdomen. So the abdomen is, there will be like central obesity, it is called. So it causes preferentially a fat buildup in the belly. So it will be like a central obesity. So remember the abnormal fat distribution here. Buffalo hump because of the fat, and then the central obesity, the abdominal obesity that is called, just also called centripetal obesity. And then you will see these stretch marks on the abdomen mostly, and these stretch marks are also called striae, and again they are because of the skin atrophy. And then relative to this abdomen and this buffalo hump, the extremities, the arms and the legs are pretty thin, so they will look really thin in these patients. And remember, cortisol also have a destructive effect on the bones, so there will be osteoporosis. Osteoporosis can occur with Cushing syndrome. That's really important to know. And another thing is that it causes insulin resistance, and that because it's diabetogenic. Cortisol is diabetogenic, so it will cause diabetes as well. So these are just the main features. Of Cushing syndrome. So it's really easy to recognize when you see a patient clinically. It's really easy to recognize Cushing syndrome. You can just look at the patient and you would know that it's most probably that the patient is suffering from Cushing syndrome. So now let's talk about causes of the Cushing syndrome. So the most common cause is just exogenous steroid use. It can be, for example, the patient has rheumatoid arthritis, the patient has another autoimmune condition like SLE. So look for anything that will require the patient to use steroids for prolonged periods, any inflammatory bowel disease. So all of these would cause exogenous, would cause the patient to use exogenous steroids for prolonged periods. And that steroid is basically here, it will act like a cortisol, and increased cortisol will then cause the Cushing syndrome. Second cause is the pituitary adenoma. Remember, we talked about the ACTH being released from the anterior pituitary. So if there's a growth here that is secreting it, this is called the pituitary adenoma, and it has a special name, and it is called the Cushing's disease. So remember, if they say Cushing's disease, just think about pituitary adenoma. Then we have the adrenal adenoma, again, another cause here. So if there is a tumor here, it will release the cortisol directly. And remember, if the tumor is here in the adrenals, cortisol will be increased, and that cortisol actually suppresses the ACTH. So adrenal adenoma will have increased cortisol, but it will have decreased ACTH. Then, and this one, adenoma, obviously will have increased ACTH. Again, the exogenous steroid will have decreased ACTH. So because you're providing it externally, and that external steroid actually is blocking the ACTH. And then we have the ectopic one. The ectopic are they're mostly just cancer related, so like lung and pancreatic and ovarian. So these are usually just from a cancerous pathology. So now then we will talk about next the diagnosis, and it will help you differentiate between pituitary and the ectopic, because both of them cause increased ACTH. So now the diagnosis here is really important. It's just like a really puzzle-like. Like if you once you understand it, you actually enjoy just kind of thinking about it and just kind of solving it. So now what happens first? So the first thing is that you should exclude in the history. You should exclude that the patient is using any steroid. Look for any autoimmune disease like we talked about. Just ask the patient in history if he's been using any medications. So exclude steroid use. Once you've excluded that, then you can do studies like tests in order to diagnose it. So there are three tests that are basically done. So the first one is 24-hour urinary cortisol. Number second is the late night salivary cortisol, and then overnight dexamethasone suppression test. So these three can be done initially, and remember the wording is really important here. They said late night. So in the question, for example, they may say early morning. So early morning is not done. It's late night, because remember, in early morning the cortisol is already elevated, right? In the morning our cortisol elevates. So that's why we're doing late night, because in late night the cortisol should be decreased levels. But if you find increased levels in late night, that means it's abnormal. That means that there is hypercortisolism. And then there is dexamethasone suppression test. We just give 1 milligram of dexamethasone, and then the next morning about 9 a.m., 8 a.m., you kind of check for the suppression of the cortisol. So if it is not suppressed, then that means that it is it's basically Cushing's, right? It points to Cushing. So if any of the above two tests are positive, then we can say it's Cushing's. You can just say it's Cushing's if any of the two above tests are positive. So let's say that the dexamethasone suppression test, the low-dose dexamethasone suppression, overnight dexamethasone suppression test is actually not positive, but the patient has features of Cushing's. So you should then look for causes of pseudo-Cushing's. So pseudo-Cushing's causes include like anything that increases estrogen, like hormone replacement therapy if the patient is on, and then OCPs, and then pregnancy. Other causes include like obesity. Obesity also causes, remember, increased estrogen. And depression is another cause, and anxiety is another cause. So these are all causes, and alcohol. So these are all causes of pseudo-Cushing's. So if the patient clinically presents as a Cushing's, right, as a Cushing syndrome, but when you do tests, the tests do not show any Cushing's. So that means that it is basically pseudo-Cushing's. And we listed all the causes of pseudo-Cushing's. So now, if two of these tests are positive, then we talked about that it is Cushing's. So now it's confirmed Cushing's. So now, the first then step we should do is do ACTH levels to know if it is ACTH dependent or ACTH independent Cushing's syndrome. So now, if ACTH is elevated, we talked about two causes of ACTH dependent. That the first one is adenoma, which is called Cushing's disease, and the other was ectopic ACTH, which is mostly because of the cancer. And if it is not elevated, if the ACTH, which means ACTH independent, for example, adrenal adenoma, like we talked about before, if there is adenoma here, ACTH will be suppressed because there is increased cortisol. And so that will be adrenal adenoma. So just do adrenal CT and it may show the adenoma here. So then here we further, like we talked about, we have to and then differentiate ACTH dependent because both of them cause increased ACTH. So we have to know which one is present in the patient. So now for that, we can either do a high dose dexamethasone suppression test or we can do CRH stimulation test. So now if we do high dose dexamethasone suppression test, and if it is if the cortisol is suppressed, that basically means if it is suppressed here, if it is positive, it is suppressed, then it's pituitary adenoma. Okay, it is pituitary adenoma or Cushing's disease. It's like adenoma can be suppressed by the high dose dexamethasone suppression test. But if it is ectopic, you can think about ectopic as really just a severe elevation in CDH. It's not responsive to high dose dexamethasone suppression, and dexamethasone cannot suppress it. It's like more aggressive because it's cancer, right? So it will be negative. The test here will be negative, so there will be no suppression. In the pituitary adenoma, there will be suppression. In the ectopic CDH, there will be no suppression. So now, if there is adenoma, you can just do pituitary MRI. If it is ectopic CDH, which means high dose dexamethasone suppression did not suppress cortisol, then it's just do CD, chest, abdomen, pelvis to look for the cancers like lung or pancreatic cancer or ovarian cancer. So another test you can do is CRH stimulation test. So now if you do the CRH stimulation test, it's actually, and if it increased, if it is positive, which means it increased ACTH, that's basically adenoma. And if it did not, that basically means ectopic ACTH. And then obviously just do the test like we talked about. For adenoma, MRI; for ectopic ACTH, CD, chest, abdomen, and pelvis. So usually you just, like in summary, you just do these three tests, and then if two are positive, then you can just go for ACTH, and if ACTH is elevated, then you should do the high dose dexamethasone suppression test or CRH stimulation test to know if it's ectopic or adenoma, pituitary adenoma. If it is not elevated, most likely it's adrenal adenoma. So now let's talk treatment here real quick. So for treatment, the first line, if it's pituitary adenoma or Cushing's disease, you do transphenodal resection, and it will resolve 80% of the cases. Then if, let's say, the patient did transphenodal resection for pituitary adenoma and still there is increased ACTH, then you can do something called irradiation. And let's say the radiation is done, there's still ACTH elevation. Then you can actually do bilateral adrenal adenectomy, but it's actually less commonly done now because other modalities are mostly just defective. Then also medications that are available that actually suppresses synthesis of cortisol, like metarapone is 11-beta-hydroxylase deficiency, which is involved in the synthesis of the cortisol, and ketoconazole inhibits 17-alpha-hydroxylase, so which is also involved in the cortisol synthesis. Another thing which is a rare kind of syndrome is the Nelson syndrome, and it is kind of associated with bilateral adrenalectomy. So if you do bilateral adrenalectomy, there will be certain decreased cortisol, and that certain decreased cortisol will cause increased ACTH that causes growth of the pituitary cells. So it actually leads to pituitary adenoma. So bilateral adrenalectomy leading to pituitary adenoma is called Nelson syndrome. So just a rare syndrome, this one. So hope this one was helpful.